Good morning, everyone. We are going to discuss the metabolic response to injury from the first chapter of Belly and Love. So, what is the metabolic response? It's the injuries response that is the integrated physiological, biochemical, endocrine, and immunological changes that occurs after a trauma, surgery, burn, sepsis, or any critical illness. So what is it? It is the its primary objective is survival, maintenance of organ perfusion, immune defense, and the wound healing. If the response is excessive or prolonged, it can become harmful. That leads to muscle wasting, organ dysfunction, hyperglycemia, immunosuppression, or multiple organ dysfunction syndrome. Historically, there are three scientists which are involved all these concepts. Claude Bernard gives the milieu anterior internal environment of the organism. Walter Kenner gives the homeostasis term. John Hunter gives the states that the injury initiates the healing by inflammatory response. So, homeostasis is the body's ability to maintain a constant internal environment despite external stress. The modern surgery aims to preserve the homeostasis through stress-free perioperative care. Goal of metabolic response to maintain the circulation, maintain oxygen delivery, provide energy, prevent infection, promote wound healing, and restore homeostasis. If the injury response is minor or minor injury or any minor surgery, there will be mild inflammatory response and the transient hypermetabolism. The patient recovers by itself. If there is a trauma, major trauma or sepsis, that leads to massive cytokine release and systemic inflammatory response, lead to catabolism. If no intervention done, then there can be multiple organ dysfunction syndrome, and it can lead to death of the person. Mediators of metabolic response. Neuroendocrine response. In neuroendocrine, the response is reached through nociceptive receptors to the hypothalamus through sending pathway. Hypothalamus release the CRS, then the act on pituitary release the ACTH act on adrenal cortex, and the cortisol release. If there is any trauma, there will be sympathetic activation which leads to release of noradrenaline and adrenaline, and the pancreas also release the glucagon to increase the glucose in the blood. Other endocrine changes are increased growth hormone, increased prolactin, decrease insulin like growth factor 1, decrease thyroid hormone, decrease testosterone, and insulin resistance develops. Cytokines, interleukin 1, interleukin 6, TNF alpha, interleukin 8. Interleukin 1 leads to the fever, hyperthermia. Interleukin 6 leads to increase in the acute phase proteins from the liver. TNF alpha leads to catabolism. Interleukin 8 leads to neutrophil activation. Function of these are fever, muscle breakdown, hepatic protein synthesis, leukocyte activation, endothelial activation. Other mediators are nitric oxide, prostaglandin, bradykinin, endothelin, reactive oxygen species. Neuroendocrine hormones are cortisol. Why cortisol important? It leads to protein breakdown, gluconeogenesis. So increase the glucose. Catecholamines, glycogenolysis, lipolysis. Glucagon leads to glucose production. Growth hormone leads to lipolysis. ADH leads to water retention. Aldosterone leads to the sodium retention. So, whenever there is a inflammatory response, they lead to systematic inflammatory response syndrome. Criteria: temperature, heart rate, respiratory, or WBC. These inflammatory response initially driven by interleukin 1, 6, and TNF alpha. A prolonged inflammatory may progress to compensatory anti-inflammatory syndrome, response syndrome (CARS). So, there is a theory called Ebb and Flow theory. This model remains the gold standard for characterizing the patient's metabolic trajectory from shock to recovery. So it is based on the time frame from initially 48 hours. There is a shock, hypovolemia, decreased BMR, decreased cardiac output, and lactic acid. Hormonal drives are catecholamines, cortisol, and aldosterons. Then comes our flow phase, 3 to 10 days. There is a hypermetabolism, increased cardiac output, tissue edema, increased gluconeogenesis, and cytokines, glucagon, cortisol, and catecholamines are the hormonal drives. Then comes our anabolic stage after weeks. The replacement of lost tissue, recovery of protein stores, and the healing. It is run by growth factors, insulin. So there is a recovery of sensitivity of the insulin toward the tissue. Hypermetabolism. There is an increase in resting energy expenditure after injury. The causes are cytokine, catecholamine, futile metabolic cycle, fever, or wound healing, or leads to metabolic. Consequences of metabolism are increased oxygen demand, muscle wasting, weight loss, negative nitrogen balance. So the modern ICU care limits the degree of hypermetabolism by timely intervention. So muscle protein catabolism. The main mechanism is ubiquitin proteasome pathway. Consequence is that the weakness, delayed mobilization, respiratory muscle weakness, increased infection, and poor wound healing. Patient with the severe sepsis can lead to the urinary nitrogen loss up to 14 to 20 gram per day, equal to 500 gram skeletal muscles loss per day. Then comes our acute phase response. Acute phase response lead to acute phase proteins. There are two type of protein: positive, negative. Positive means the level of this protein increase. Negative means the level decrease. Increase are CRP, fibrinogen, ferritin, complement system, and the serum amyloid A. Negative albumin, transferrin, and pre-albumin. The liver reprioritises the protein synthesis towards the positive acute phase proteins. Insulin resistance develops after surgery, trauma, sepsis. The mechanism is simple because of cytokine, cortisol, catecholamines, or reduced insulin sensitivity at the receptor level. Effect of these insulin resistance is hyperglycemia, infection, poor wound healing, and increased ICU stay. Management favors the controlled glucose management while avoiding hypoglycemia. During major injury, there will be fat loss, skeletal muscle loss, expansion of extracellular fluid. Weight may initially increase because of the fluid retention despite ongoing catabolism. The available factors that exacerbate the response are continued hemorrhage, hypothermia, tissue edema, tissue hypoperfusion, starvation, and hypomobility. Correction of these factors reduce the metabolic stress and improves the recovery. Modern perioperative care includes minimal access surgery, normothermia, goal-directed fluid therapy, adequate analgesia, either epidural, regional, because it decreases the neuroendocrine pathway response. Early enteral feeding, early mobilization, glycemic control prevents from nausea and the ILS. These measures reduce the neuroendocrine stress response and preserve the homeostasis. So most important cytokine for acute phase protein synthesis is interleukin 6 from the liver. Most important catabolic hormone cortisol, anabolic is insulin, and most main pathway for muscle degradation is ubiquitin proteasome pathway. Duration of Ebb phase is 24 to 48 hours. Catabolic phase of flow is 3 to 10 days. Major positive acute phase protein CRP, negative is the albumin. Main fuel for immune cell and enterocyte glutamine. Most common metabolic abnormality after major surgery is the insulin resistance with hyperglycemia. Thank you.